So today we're going to try and focus on causes of the red eye or red eyes in ophthalmology. But before we do that, I thought it would be useful to slightly talk about what you should focus on in ophthalmology. So I kind of split it up into some random categories that you may or may not find useful. Causes of the red eye and the causes of visual loss are like the two really big things that come up a lot. Because they tend to be quite acute emergencies, some of them. So learning those is quite important. And there's a fair bit of overlap. So I think Ophthal, out of every specialty in year 5, has the most overlap with 4th year, because there's a ton of neurology stuff. So like all of the stroke stuff can come in because all of that can cause visual loss. And then there's lots of systemic disease manifestations within the eye. So I think this is like the really important stuff. We can go into visual loss another day, and we can go into like retinal pathologies another day. But I think this is like a good list of things to start with. I haven't really put like the details on the slide, but what are some like common causes of blindness that happen within the eye and not to do with like the brain? You can just type in the chat. So common age-related macular degeneration, absolutely very, very common cause. Trauma, yeah, common cause. What else? Cataracts. Cataracts are the commonest cause of reversible blindness. Retinal detachment. Yeah, there's loads and loads of stuff. Also, at the end, if anyone is interested in the Duke Elder, we can talk about that briefly at the end as well, because that's an exam that people often do in 5th year. You should, you shouldn't be pressured into doing it, but if you're interested, stick around. Fine. How do we categorize the causes of a red eye? There's two ways to do this. So any ideas? There's 2 systems we can use. So anatomically, absolutely, you can categorize it anatomically, yes. And then what's the other method that we can use with every single thing? Surgical sieve. So etiologically as well. Yeah, you can do acute and chronic. So I've done all 3. I've split everything up in 3 different ways. So like whichever one you like, you can use. So you can do it anatomically, etiologically based on the surgical sieve, or you can do it based on acute versus chronic. So unlike a lot of things, I think that the anatomy of the eye is super useful in understanding how things work. So here's like basic anatomy of the eye. You have 3 layers. You have the retina and the optic nerve, which is the neurological component of the eye, followed by the kind of vascular / muscular component, which is the choroid, ciliary body, and iris, and together these are called the uvea. So those go all the way around, and this is later split up into the posterior uvea and the anterior uvea, and this will become clear later when we talk about why that is. On top, around these, we have the sclera, and that's like the white bit of the eye that you see. And then, so those are like the 3 layers of the eyeball itself. The refractive apparatus is very important. So what bits allow us to refract light appropriately? There's 2 bits to this. Lens and cornea, absolutely. And which one is responsible for more of the refraction? The cornea is, yeah, absolutely. And the lens is more like an adjustment tool. So the cornea is the bulk of the refraction, and the lens is just a correction. So it's useful to think of in that astigmatism is a problem with the shape of the eyeball, which will also affect the shape of the cornea to an extent. So like you get both things going wrong, which is why people with astigmatism tend to have very blurry vision. But we'll talk about that like another day. Then on top of these, you have the mucous membrane. So any part of the body that is exposed to the outside requires a mucous membrane to protect it. And the mucous membrane for the eye is known as the conjunctiva. So you have two bits. Does anyone know what they're called? You have the bit facing the eyeball and the bit facing the eyelid. They have two different names. So no ideas. So you have the palpebral conjunctiva and the bulbar conjunctiva. The palpebral one goes along with the eyelids. The bulbar ones goes around the bulb, which is the eyeball. So those are the two aspects of the conjunctiva that you need to know. And then you have the various chambers. So you have the gray bit in this diagram, which is the vitreous chamber, and that's like a jelly. And you have the aqueous chamber, which is split into posterior and anterior around the iris itself, and that's in white here. So another thing to just remember, anything in this line of the cornea, the lens, anything in the line of the cornea, the lens, and the retina, anything goes wrong between that kind of area can cause changes with your vision. But we're not going to talk about visual loss today, so we'll recap it when we do it then. The reason this is so important, and then you have the muscles around the eye that helps move them, and you know that from last year, I hope. And this is really important because depending on which part of the eye is red, you'll have pain or won't have pain. So a general rule is if you've got your conjunctiva involved, it's painless, and everything else is painful. But there's some other less pattern stuff, and I know that this is like one of those useless like categorizations, which is just saying other. But yeah, if it's the cornea, sclera, or uvea, it's painful. If it's the conjunctiva, it's painless. Is just a general rule for you to remember. The other way to do it is to do it based on etiology. So these are in some infectious causes. So what's infection of the conjunctiva called? Not a trick question. Conjunctivitis, absolutely. What's infection of fluids called? It commonly happens after like surgery. This you might not know. That's fine if you don't. Endophthalmitis, yeah. So end referring to like endothelium kind of ish. So the inside of the eyeball is infected, and that's a ophthalmological emergency. Then you have these inflammatory conditions, which are all the interesting things that we'll talk about later, and then you have problems with the actual anatomy of the eye, and we can talk about those as well in a minute. So hopefully you didn't see those questions, but what kind of questions do you want to ask when someone comes in with a red eye? So what are the associated symptoms of a red eye? Is it painful or is it not painful? Yes, that's the first thing. What else? Yeah, if they've got any changes in sensation, gritty or itchy, tearing, discharge, absolutely. Visual change is very, very important because only some of them cause visual changes. Dryness, yes, because dryness itself can cause a red eye. Those are like the important things. Yeah, great. You also want to know how much of the eye is red. We'll mention because most of them cause a fully red eye. There's a few that only cause sectoral redness. Discharge we talked about. If they have discharge, what kind of discharge is it? Because that'll help you narrow it down as well. Visual symptoms, very important. Anything with the eye, do you have visual symptoms? If they do, it's probably something worse than something that doesn't cause visual symptoms. And remember, like ophthalmology, like rheumatology, it's very important to take a very comprehensive history because there's lots of systemic conditions that cause lots of weird things in the eyes. And likewise, there's lots of drugs that can cause problems in the eyes. So this is what we're going to talk about today. We're going to talk about the emergencies first because that's important, and then we're going to talk about everything else. So if you're going to take away like if you're only going to learn a certain amount from this, learn about the emergencies because you can read up on the rest later. So this is Mrs. QS. This is a brief vignette. I want three differentials based on this history. If you haven't done Opthal, don't worry about it. If you have done Opthal, try your best. We'll talk through them anyway in a minute. Acute angle closure glaucoma should always be your number one differential diagnosis that you need to rule out before anything else. Yes. GCA is a good shout, but GCA traditionally doesn't actually cause a red eye, but it's a good thought. The way GCA tends to work is it causes ischemia to the head of the optic nerve itself, and it causes it to die. So you get like an optic neuritis, not an optic neuritis, you get an optic neuropathy. But it's a good thought. Also, it's a rheumatological condition, so it probably could cause a red eye in some random circumstances. So never rule out. Cluster headache, yeah. So neurological cause of a red eye is a cluster headache, yeah. What else? What if I told you they had a history of ankylosing spondylitis? Yeah, it could be uveitis, which is commonly anterior in that case. What else? What else is interesting? What if I told you that they've just had a cataract surgery? Yeah, and ophthalmitis. So the differential based on these things is actually pretty wide. I've only put 3 on this slide, so I put these 3. To be fair, so it could still be trauma. It could still be conjunctivitis, or the blurred vision makes that significantly less likely. Then, so the next thing you're gonna do is you're gonna look at her pupil, and you see this. So can someone describe what so there are 2 things going on in this pupil, in this eye. There is one that's obvious, and there's one that is slightly less obvious. And so what's the obvious finding in this eye? Is the color normal? Yeah, so this is an injected conjunctiva. So what this means is around the redness, it's almost like a circular pattern. Yeah, so yeah, it's a red eye. You don't actually need to know about the different types of redness so much for your exams. If you do the Duke Elder, you will need to know that. But yeah, okay, so that's the big finding. What's next? Tell me about the pupil. Oh yeah, so it's a misshapen pupil. So there is a specific description of this pupil that will give away the diagnosis. But what things cause misshapen pupils? So we've got our differential based on the history. Now, what's our differential based on the examination? So again, give me like 3 causes of weird shaped pupils or incorrectly shaped pupils. Could be anterior uveitis. So when you get inflammation of the anterior uveal tract, the pupil can stick to the front of your eye and it can not be perfectly round. What else could it be? Increased intraocular pressure, less likely. Could be due to it. Depends what type of increased intraocular pressure. Are you referring to acute or chronic? I mean, we're talking about an emergency here, so that should give you a clue. It's acute. So in chronic glaucoma, where they have increased intraocular pressure, they tend to have a normal pupil. In acute angle closure, they tend to have like a slightly weird pupil. That's two. And then the third cause is cheating, because neurological things can always cause funky pupils. But yeah, those are like the three things you want to be thinking about when you see a weird pupil. So yeah, chronic glaucoma we're not going to talk about. It tends to have like a normal pupil. Acute will have a misshapen pupil. So this is if you compare the two lists, the one diagnosis we have in common is actually acute angle closure glaucoma, and that's generally a good thing to do for ophthalmology. If you can create a differential based off your history and a differential based off examination, like in an exam question, you'll get the diagnosis most of the time. Angle closure glaucoma is where you get closure of the trabecular meshworks you can't reabsorb. You tend not to reabsorb aqueous fluid, so you get an increase in pressure of the eye. Presentation, you get the short history of a red, painful eye, you get blurred vision, halos, and it causes you to be systemically unwell because it's just really, really painful. So these patients have nausea and vomiting. On examination, importantly, you get this fixed mid-dilated pupil. It's a very specific finding, but if you see like a slightly weird pupil, it's something to keep in mind. Investigations, you do this thing called gonioscopy, which tells you how open the trabecular meshwork still is, and to see if the canal of Schlemm has closed off due to the small angle. You don't need to know the specifics, you just need to know that it's called gonioscopy and it tells you whether that canal is still open. The canal, you can Google what the canal is, it won't really come up in exams. Do you know what field defect, visual field defect you get in glaucoma? Anyone have an idea? Yeah, so yeah, you tend to get like a peripheral visual loss. I mean, if you don't know the answer, peripheral visual loss is always a good shout, unless it's neurological, then it won't be that. Management of acute angle closure is you give them IV acetazolamide, which helps for a reason that I can't remember off the top of my head. I think it's a carbonic anhydrase inhibitor, which works in the eye. I think it either reduces secretion or increases reabsorption. I can't remember off the top of my head, but the definitive treatment, that's just symptomatic. Definitively, you need to drill a small hole in their eye, which allows drainage. You tend to do it in the other eye as well. You do a bilateral one, because if they've had acute angle closure in one eye, they're more likely to get it in the other eye as well. So it's really important that you do both eyes. This is an emergency. So what is the problem when you have increased intraocular pressure? So in either acute angle closure or chronic glaucoma, what's the problem? Having a high intraocular, except for the pain and the symptoms. Do you know what the danger is? Yeah, so you compress you damage the head of the optic nerve, and it kind of just starts to necrose, and you can lose your vision due to it. So it's really important that you manage this. Right, here's a spot diagnosis. What's this? So this is a corneal ulcer. That's exactly what this is. And what normally causes these corneal ulcers? Yeah, so it could be microbial, but like the really important ones you need to remember are the herpes related ones. And there's actually two. So keratitis is inflammation of the cornea, and this is an emergency because you can wreck your cornea pretty much. Important findings specifically is reduced. Investigations are really strange. So you can, if you fluorescent dye them, you'll see that really weird image that I just showed you, where they have like a dendritic pattern. Corneal scraping is very useful. You can do like culture and sensitivity in case it is microbial. And anyone with this needs an HIV test, because this is a severe infection and may suggest immunosuppression. So if they get it and they're not on like immunosuppressive medication, they might have HIV. So don't forget to do an HIV test. You also do a full blood count. Why do we do a full blood count? in this case. Some year 4 revision. Any ideas why we do a full blood count? It's to do, yeah. So actually, that's interesting. So you could look at the white cells for infection, but funnily enough, sometimes infections of the eyes don't necessarily cause white cells to increase. But yeah, you could definitely look for that, especially if they've got an infection that's spread to the eye. The other thing is certain like hematological malignancies can cause suppression of your immune system, and this might present like this. So you also want to do a full blood count for that reason. So it's like a 2-hit thing. Lots of causes of keratitis, as we talked about. With that dendritic pattern, you're most worried about a viral herpes virus keratitis, but here are some other causes. A viral cause, very important. You've got herpes simplex keratitis. Type 1 is more common than type 2 because type 2 tends to affect the genitals more than type 1. That's historical. In modern day, it doesn't really happen like that, as you'll learn about in gum. And then you also have varicella zoster keratitis. The one you're more worried about is herpes simplex keratitis, and you need to treat it with topical gancite. And you need to be ensure that like you think about this and you do not treat with steroids because it will go into a full-blown infection and it will cause blindness. Varicella zoster keratitis is reactivation in the ophthalmic branch, which then spreads to the eye. This you can treat with oral acyclovir. This isn't as serious. So herpes is more severe than zoster, is what you would need to take away from this slide. Here are some signs. So what's the sign on the left? It was on the previous slide. Hutchinson's sign of the nose. I would just remember to specify because there's lots and lots of different Hutchinson signs, and some old consultant will probably wreck you for no reason. What's the second thing? HSV on the lips, yeah. And the last thing, yeah, herpes labialis, absolutely, cold sore. Synonyms, yes, all correct. And the last one on the right. Yeah, varicella zoster reactivation and the trigeminal distribution. So not the trigeminal distribution, a bit narrower than the trigeminal distribution, because if it was the trigeminal, it would be the entire left-hand side of the face. So if I asked you to be a slightly more specific, where would you say it is? The ophthalmic division of the trigeminal nerve, yeah, absolutely. And this is called herpes zoster ophthalmicus. And this is awful and really painful because shingles is awful and really painful. Other causes of keratitis, bacteria. You can read this slide in your own time. The important thing to take away here is do not swim in contact, because you can get like this acanthamoeba keratitis, which is very, 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 very painful, and it's quite hard to treat. You almost definitely saw the answer to that. Does anyone know what's going on here? If you didn't see it. Okay, yeah. So this is a fungal keratitis, but it's good because this is a really important finding. You have pus in the anterior chamber of the eye. What do you know what we call that? Like there is a medical term for having pus in the anterior chamber of the eye. Hypopion, absolutely. And instead of pus, if you had blood in the anterior chamber of the eye, do you know what that's called? Here's another term that you kind of need to know. Yeah, high femur, high femur. Yeah, high femur. Yep, absolutely, that's correct. Does anyone know what the diagnosis here is? So the clue is the pupil looks swollen and disgusting, and there's no hypopyon. This one won't come up in your exams, to be fair. This is acanthamoeba keratitis. It's kind of a spot diagnosis. Take it in your head, and if you see something that doesn't fit into the other boxes, it's amoebic. That's the really, really, really important acutely causing blindness stuff done. So now we'll talk about like the less urgent stuff that you will more likely see. So conjunctivitis, as we talked about, is inflammation, often due to infection of the conjunctiva. Oh, have the slides disappeared for other people? Yeah, try leave and rejoin, or see if it's minimized to the bottom of the screen. What are the 4 big causes of conjunctivitis? There are 4 really important causes. And they can ask you about each of these in an exam. Allergic, viral, bacterial. So the reason it's 4 is because for some reason ophthalmologists love splitting up bacterial into bacterial and chlamydial, because they present slightly differently. But yeah, they're groups. So bacterial conjunctivitis. So I have clues for you. So what is the discharge like in bacterial conjunctivitis? Is it watery? Is it pussy? Or is it like a mix of both? Or is there no discharge? Those are your options. Sticky with pus, absolutely. Purulent is the word they love to use. When you look underneath the eyelid, as you should when you're worried about conjunctivitis, but you probably won't because nobody does. What will you find on the underside of their eyelid? You can find follicles, or you can find papillae. Do you know what you would find in bacterial? So you have like a 1 in 2 chance of getting this. No worries. So you tend to get papillae. We'll go through the difference between papillae and follicles in a minute. Fine. Do they have any associated systemic symptoms when they have a bacterial? If you have a bacterial conjunctivitis, is the person going to be otherwise well, or are they going to be otherwise quite unwell? So actually, so here's an important thing. With bacterial conjunctivitis, you have a localized infection of the eye itself. So they tend to be quite well. They'll feel awful because of their eye, but they're otherwise pretty damn well. Important causative organisms, any ideas? Staphs, streps, yes, the usual stuff. And then like if you're not immunized, fine. And management is important. So you use topical chloramphenicol. If they're pregnant, you tend to go with fusidic acid topically, but I doubt they're going to ask you that. But topical chloramphenicol is the go-to for treatment. Let's do the same thing with chlamydial. So discharge. Discharge will they have this time? I'd recommend like maybe like when you get a chance, make a table of all 4 of these types and learn each of these things, because it will come up in your exams. There'll be 1 question at least. So there's a specific type of discharge for chlamydial. Does anyone know? So it's halfway between purulent and just Palpebral findings, you get follicles this time. Associated symptoms, right? So a chlamydial conjunctivitis, what kind of other symptoms around the body might they have? The clue is in the cause. Yeah. So what symptoms are those specifically? You might not have done mod B, but you can probably still guess. So what? Painful urination because they get urethritis, dysuria. Yeah, absolutely. Or they'll have, or if it's female, they might also have cervicitis. Those are the important ones. Causative organism is Chlamydia trachomatis. And then management of this slightly different. You give them systemic tetracyclines, unless they're contraindicated. Then I have no idea what you do. I never learned the second line for this. Fine. Viral. What kind of discharge? Viral is the most common cause of conjunctivitis. How does infection spread to the eye from the chlamydia? I'm not actually sure, but like I'm sure you. So in kids, it can happen during delivery. So that's actually a common thing that can happen. And then infection can also spread like through oral sex and things like that. So like there's a variety of methods. I'm not sure whether it can spread like through the bloodstream. I can't remember. You'll have to check that. But I think those two are probably pretty common methods. Adenovirus is the commonest cause of viral conjunctivitis and is the commonest cause of conjunctivitis overall. Definitely by far. Discharge type. So what? Watery discharge, viral infection cause pus. Palpebral findings, follicle. So everything that isn't bacteria is follicles, is the way I remember it. This time they're going to have OT symptoms and they might have lymphadenopathy. We spoke about adenovirus. Yeah, you can't do anything about this one. Sorry. So just wait it out. There is some role for steroids, but you don't need to know that, as in it's just a thing that GPs occasionally do. Allergic, I'm just going to go through. But like the important thing for allergic is they get these giant papillae. So it's like bacterial, but they're freaking massive papillae. I just said that everything except for bacterial is follicles. I lied. Sorry, I completely forgot about this one. They might have fevery type symptoms. Pollen isn't an organism, but that's what causes it. And you can use topical antihistamine or mast cell stabilizers. So does anyone know what our go-to mast cell stabilizer is? You might never have heard of it, but like this is a drug to recognize rather than remember off the top of your head. Yeah, sodium chromoglycate. I'll put it in the chat. Yeah, sodium chromoglycate, and it is so remarkably expensive. It's a really expensive drug to buy. You can get it over the counter, and it's really expensive, and it's annoying. What does this image show? This is not a trick question. This is bacterial conjunctivitis. This is purulent discharge. If you see that, you have the diagnosis immediately. That's particularly nasty. What are these? So this is the bit that confused me for a long, long time. So are these papillae or are these follicles? Battery's going. Okay, so James thinks they're palpebral follicles. Why do you say these are follicles? over papillae. Just went for the 50-50, fair. So these are, you guessed correctly, these are follicles. So the thing I want you to look at is look how round and well demarcated they are with vessels running around the edges of them. That's what follicles look like. Now the next slide is papillae, and with an eye of faith, you may recognize that there are some vessels running through the center. For example, the middle one, they're less organized and less well demarcated, and that's the difference. But you will have to use an eye of faith. My slides have just stopped working. Can you still hear me? The giant papillae just look like papillae but bigger. You won't be able to you won't need to distinguish between giant papillae and papillae. I wouldn't worry about that. I'm just going to stop presenting my slides for what is going on. Let's just stop doing that for a second. Let me just share them again. I have no idea what just happened. They won't ask you to distinguish between two sizes of papillae in exams. I can guarantee you that. I don't think they'll even ask you to do that in the Duke Elder if anyone decides to do that, because you just can't tell the difference unless you put them side by side. Okay, so conjunctivitis is really important. Comes up in exams often. Comes up in GP as well. It comes up under GP, and it can come under Ophthalmology. So it's like a two-hit thing. So definitely worth spending time learning. Let me share slides again. Sorry. Fine. So what other inflammatory eye things can you think of while I catch up on slides? So we mentioned three things that can also get inflamed in the eyes. What were they? So you can have episcleritis and scleritis, both which are inflammation of the sclera or the layer between the sclera and the conjunctiva. Yeah, and then the last thing was, or arguably the most important red eye cause that isn't acute and comes up a lot in exams, even though it's not that common in real life. It's not rare in real life either. Beginning with A, associated with ankylosing spondylitis. Retinitis pigmentosa, it does not cause a red eye. Retinitis pigmentosa only causes blindness. Oh my god, why do I have so many slides? Right, skip. You can read over these, and we've already been through them. Fine. So, follicles, papillae, look at where the blood vessels are. So inflammatory eye disease, anterior uveitis, scleritis, episcleritis. Anterior uveitis is inflammation of the anterior uveal tract, so not the choroid, because that's the posterior uveal tract. You're going to look at the iris and the ciliary body, and those are inflamed, which causes the entire eye to become red. Scleritis is inflammation of the sclera, which is the white bit of the eye. Episcleritis is inflammation of the layer between the two. So all of these are pretty painful. Episcleritis is the least painful of them. So here's a short vignette. So he's got a painful left eye with reduced visual acuity and blurring with no discharge. If you know if you understand the name, you will get the diagnosis immediately, because this is the name of a condition in another language or in another part of the world. So hopefully these were the things you were thinking about. It's all things we talked about before. It's got a painful red eye. You want to be thinking about acute angle closure, uveitis, scleritis, all of the causes of a painful red eye that we spoke about earlier. As you can see, acute angle closure is still at the top of the list because it's the thing that you have to rule out before you go any further. So this is what you see when you look at his pupil. So there are there are three findings on this image. What are they? There is a misshapen pupil. What else? There is an injected conjunctiva. There is redness. Again, you can see it's like a circle around the pupil. And there is hypopion. You have this collection of pus, which is like neutrophils in the anterior chamber of the eyes. If you see these three things, there is one diagnosis that you should definitely always think of. Does anyone know what the diagnosis is? Yeah, so this is anterior uveitis. If you see these three things, it's going to be anterior uveitis. So this is what we were talking about earlier. So when you get inflammation of the anterior uvea, the inflammation causes the stuff at the front to kind of stick together, so you get like this misshapen pupil, and that's known as anterior synechia. The danger is sometimes if you don't treat it, it can stick to the back. It can start sticking to the lens. So you get posterior synechia, which can cause visual disturbance, which is very dangerous. Okay, so anterior uveitis. Red painful eye with reduced acuity and photophobia because you've got pupillary disturbance, so you get changes in your acuity, and you can get photophobia because you can't compensate for extreme light. Associations we'll talk about next slide, very important. You get ciliary redness, you get this weird pupil shape due to anterior synechia, and you get hypopion. That's like the three important. It's almost like a triad that goes along with anterior uveitis. What are the complications of anterior uveitis? There's a few important ones. I mentioned one of them just now. Any idea what the other ones are? So important ones to think about. I don't know why that came up first. Posterior synechia, where the iris adheres to the lens due to the inflammatory processes, can cause glaucoma. If that happens and it closes the angle as it sticks to something else, you can get like an acute angle closure on top of the anterior uveitis. God knows how painful that must be because you have two like awful things happening to you at the same time. It can then spread the inflammation, especially like if it's an infective cause, it can spread and cause inflammation of the choroid, which can cause like things like blindness, which is really dangerous. And you can get, if you get swelling at the back of the eye, you can also get macular edema as the fluid builds up. And macular edema can cause issues with your vision again. So these are 4 complications that I reckon are worth learning. Management, topical steroids, and you give them a topical mydriatic, and that prevents the synechia from forming. So what does a mydriatic drug do? So there's miosis and mydriasis. So what's the difference between the two? Yeah, so it's a drug that causes mydriasis, which is pupil dilation. Absolutely, yeah, all of you are correct. Good. So the management is quite important. Associations of anterior uveitis is all of this weird and wonderful stuff. So you have notably the HLA-B27 associated spondyloarthropathies. And Behçet's is also important. It's a very common cause of an anterior uveitis. Behçet's also causes posterior uveitis, but that doesn't really come up in exams. Lots of TB can cause it, psoriasis can cause it, and then relevant to year 5, syphilis can, especially when you've got tertiary syphilis with neurological involvement. Toxoplasmosis is the commonest cause of anterior uveitis in children. Toxoplasma gondii is a remarkably common infection. It's just asymptomatic in most of us. the viruses. So these are important. So if you're going to remember, the ones to remember are HLA-B27, Behçet's, syphilis for year 5 especially. So this is Bacterial disease, by the way, in case anyone was interested, is a European term for ankylosing spondylitis. Hence the clue in the name. Sectoral redness. So what condition, does anyone know what condition causes sectoral redness? So only a bit of this eye is red. Yeah. So it's important to know the difference between episcleritis versus scleritis. Episcleritis tends to be sectoral redness that blanches, so it goes back to white when you put topical phenylephrine. It's also way less painful. Someone with scleritis will be like in agonizing pain. The other thing about scleritis is you actually get thinning of the sclera, so you can start seeing into the eye, and that causes like this bluish hue. You really do need to treat scleritis. Episcleritis tends to be self-limiting. There is a type of scleritis that is painless and can cause perforation of the sclera. I don't know if anyone's heard of that. Does anyone know what it's called? There's been a few cases at the Royal Free. We'll talk about it in a minute, because it's interesting above all else, even if it doesn't come up in exams. So what does this image show? Yeah, so this is the thinning of the sclera, and you can kind of see into the chambers of the eye with the bluish tinge, which happens in scleritis. Yeah, you're right. Actually, the bottom there is a bit of the choroid showing as well. Yeah, I hadn't even spotted that. Nice. Scleritis is all the weird and wonderful stuff. So, what would you say is what is a common association with scleritis? There's two really big ones, and then there's less common ones. So rheumatoid arthritis is probably the biggest single association of scleritis, and then HLA-B27 can still cause it, but less commonly. RA, lupus, granulomatosis, polyangiitis, basically vasculitis is like vasculitis rheumatoid is like the big cause of it. So a strange phenomenon you can get with rheumatoid especially is you can get a painless scleritis which perforates the sclera, and that's called scleromalacia perforans. I'll put it in the chat. If you want to be kind of disgusted, you can Google it. It's a very rare subtype of it, and it's completely painless. But yeah, the important ones to remember are RA and GPA. The rest of them not so much. But yeah, those are the important causes of a red eye. I will note, here are some ones we haven't talked about today. So we spoke briefly about endophthalmitis. So notably, if you've had cataract surgery and there's been contamination of the ocular fluids by commensals in the eyelashes, you need a vitreal surgeon to fix this, because you probably need to remove the vitreous humor. This is an emergency and can cause blindness. There are problems outside of the eyeball that can cause irritation to it and cause redness. So any cause of dry eyes or lower motor seventh can cause a red eye. And then you have these eyelid pathologies. So like you can have inflammatory or infectious things that are going on with the eyelid that can rub against it, like blepharitis or styes. Or you can just have a basic anatomical issue with the eyelid. So does anyone know what entropion and ectropion are? Sorry. So ectropion, so ect, everted, so the eyelid is facing outwards. So you're getting incomplete coverage of the eyeball. Entropion is where you've got the outside of the eyelid touching and brushing against the eyeball, which again causes irritation. So hopefully that gives you an idea of what you kind of want to learn for ophthal. Go up and read up on these because they come up. You don't need to read up a lot. You just need to know roughly what's happening. I'm going to stop the recording there. If you have any questions, stick around. If as usual,